Welcome to the review for exam number one. My intent is to highlight um, some essential um, material that I'll ask questions on for the exam on Monday. Okay, so the first slide coming up. Um, know the patho terms and definitions. This is going to be important because that's going to be the language of pathophysiology. So this is kind of a laundry list of the different conditions. It's going to be an objective type of question where I would ask maybe about, what is a sequela, or what's the difference between an acute and chronic, but it just would be a couple of questions. The same thing with the cells that change, adapt to the environment. This becomes very important as far as knowing the difference between atrophy and hypertrophy and hyperplasia. Again, they're going to be very straightforward, multiple choice questions. Um, and that just brings us to hemostasis. Now, the thing about the hemostasis is just to review in your mind the different stages, so that after a person cuts themselves, they're going to have a vascular spasm, and then they're going to make a platelet plug. And then that will set things in motion that will result in a permanent fibrin blood clot, and then the bleeding stops. So review this, know this. I'm not going to ask you a question about the initiation or amplification or things of that nature, but I do want you to know what comes first, second, third, that type of thing. And it might be like 1 2 point question, but to know the vascular phase, and then your platelet plug, and then your coagulation phase. So aggregation would be the platelet plug, coagulation is going to be the fibrin blood clot. Now, that is needed to understand about the two different types of diseases that would be on the exam. Again, a couple of multiple choice questions. So you have a primary disorder, and that example of that is going to be von Willebrand disease, named after Dr. von Willebrand. And this primary disorder is a genetic disorder caused by a missing clotting factor named after von Willebrand. But know that it's about platelets. So with von Willebrand disease, the child cannot make platelets. So it's a platelet disease. So if you can't make a platelet plug, you can't proceed. Now, a secondary disorder is hemophilia. So here you have a hereditary genetic bleeding disorder in young boys. And I'm not going to ask you about which specific or what's the difference between hemophilia A or B, but that they are lacking a clotting factor. And that clotting factor means that they cannot make a fibrin blood clot. What's the difference between the two? A child with hemophilia can make a platelet plug. That's not a permanent solution, but at least it gets to be a platelet plug. A primary disorder like von Willebrand's, that they're going to bleed much more easily, if that's possible, because they can't make a platelet plug, so they can't obviously make a fibrin blood clot. And that should be it for for hemostatic disorders. Now we're going to go right into cancer. And the thing about cancer is to know, for example, for a 2 point multiple choice, autonomous versus anaplasia. Autonomous means that they are independent of cell cycle controls. Anaplasia means that as the cell becomes malignant, they lose their differentiated function. So if it was a cell that was involved in peristalsis, for example, where the food was moving down the esophagus, then the cells that are neoplastic are not going to function and be able to do peristalsis. So that's their loss of their ability to differentiate and do a specific job. In the cell cycle, know that it's the S phase where you mutate. That's where the cancer is going to be caused, because the mutations are going to affect DNA replication. And that's the opportunity that the carcinogens have to change it and turn on mechanisms that lead to neoplasia. But on the other, and then mitosis is obviously a phase that it also manipulates, but S has to come first. You have to mutate that DNA first, and then followed by changes in things like mitotic rate. Also know benign versus malignant. Top one 2-point question. A benign tumor is a excuse me, an encapsulated tumor that does not spread. It does not metastasize. So it's very easy for a surgeon to go in and to take out the benign tumor. Where it gets tricky, this will not be on the exam, but brain tumors are very often benign. But they're growing in the brain, and the tumor has no place to go but to crowd out normal cells. Having said that, returning to this, one of the things that you do need to know is cancer nomenclature. Again, multiple choice, but it becomes important because it becomes the language of that particular field of oncology. The part that is the trickiest is not the fact that the tissue in which it originates. That makes a whole lot of sense, right? So if you have a bone cancer, then you're going to call it a sarcoma. But and you're going to then refer to the origin of the primary tumor. This next part, the embryonic tissue of origin, is a little bit odd in that what they want to do is, you got an organ, and like bone. Let's take bone. So you could have an osteo. Osteo is going to be the tissue in which it originates, but bone has a number of different layers of cells. It has epithelial cells, it has connective tissue cells, it has bone. I'm sorry, obviously it has bone. It has blood, it has nerves. So what the oncologist wants to do is to not only say that it is bone in nature, osteo in nature, but it wants to say which tissue is malignant in that bone. So what they decided on is the embryonic origin. So for cells that were originally in the embryo, ectoderm or endoderm. Ectoderm is skin, brain. Endoderm is linings of like the GI tract. If that is the original place where the neoplastic transformation took place, then you're going to call it a carcinoma. If it's mesoderm, muscle, bone, then you call it a sarcoma. So a bone, an osteosarcoma, that tells you that the osteo is bone and that it's the mesodermal cells, sarcoma, that were affected. All right. So I'm going to go forward, and the genetic basis of cancer. This is obviously very important, and there'll be a number of questions on this because cancer is a genetic disease. Cancer is a mutation or translocation of your DNA, and that is enough to take a normal cell and have it grow and divide uncontrollably, lose the ability to do programmed cell death, lose its ability to differentiate. So it comes in two flavors. The majority of the cancers are going to either be proto-oncogenes. These are genes that control cell cycle, and mutate them into oncogenes. That causes too much cell division. Or a primary cancer is going to be biopsied and the people are going to look at it and find that it's a mutation in tumor suppressor. What the mutation does is it inactivates tumor suppressor. And that means that you have too little programmed cell death. And apoptosis is the scientific medical term for cell suicide, programmed cell death. And so cancer can be caused by either too much cell division, the oncogenes, too little cell death, inactivated tumor suppressor genes. What they all have in common, no matter what the cause of the cancer is that you are going to interfere with cell proliferation, differentiation, and apoptosis. Okay, so, and this just goes a little bit more into what they are. All right, inherited cancers. That's the two-hit theory of cancer. And what we realized when we studied the two-hit theory of cancer is a lot of cancers are two-hit. What that means is that if you do not inherit a cancer-causing gene from a parent, then you have two hits. The first hit is not going to cause a malignancy. The second hit, which could be years down the line, is going to be the malignant triggered, and the cell will turn neoplastic. What we know from inherited cancers is that the child is born with a hit. The parent gave them the hit. The first hit is inherited from the parent, and that means that they are much more susceptible to developing cancer because all they need is one more hit. And we discussed the BRCA1 mutation leading to breast cancer as an example of that. Now, oncogenic viruses, I'm just going to do hepatitis C because that is an example in people who have chronic hepatitis C. It can lead to liver cancer, which is called a hepatocellular carcinoma, because certain viruses like hepatitis C insert their viral genome into the chromosomes, in this case of the liver, and that is going to be a kind of a hit and miss. They could live their entire life being a hep C positive person and never develop cancer, or they could have the virus integrate into a specific oncogenic gene, and then the person would end up with a hepatocellular carcinoma. So that's a very well-documented example of a oncogenic virus. All right, now that brings us to metastasis and angiogenesis, because that's really what kills you. Metastasis, when the primary tumor gets large enough, some break off, they enter the bladder lymph, so that's intravasation. They then go to a distant site, and then they come out into that organ, and that is called extravasation. And what then they're going to be doing is they're going to be trying to get blood vessels growing to them so that they can grow and divide and so forth and so on. The favorite organs for metastasis, liver, brain, bone, and lung. That I do want you to know. The angiogenesis is to feed the secondary metastatic tumor. I do want you to know VEGF, I will definitely put in parentheses, vascular endothelial growth factor, because that is what causes angiogenesis. The secondary tumor will release it, it'll diffuse. If there's nothing to block it, then it encourages the growth of capillaries to the metastatic tumor. And that's going to allow the metastatic tumor to grow very rapidly. Okay, so that brings us to the different types of cancer. I did not go over this in class. It's a 2-point question on the exam, and it has to do with a skin cancer called melanoma. The other skin cancers are not considered dangerous because they either don't metastasize or do so very slowly. The killer, skin cancer, is melanoma. And it means that the melanocytes, the cells that give you skin, a pigment, can transform themselves into one of the most malignant, most rapidly spreading cancers of the body. The problem being that when you look at a melanoma, there's no pain or there's no tumor that comes out of the person's skin. It's just a discoloration with irregular margins, blah, 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 blah. So very often what brings the person, especially if it's in the back and they can't see it, what brings the person to the doctor is the metastatic spread and the symptoms that that causes. And if it gets to that point where it's already invaded into the liver, then it's a very hard cancer to treat, and death almost always ensues. So that's the only one that I want you to know for skin cancers. And that brings us to leukemias. And of course, the thing about leukemias is that there are stem cells in bone marrow that undergo some change as they grow and differentiate into mature cells like red blood cells, erythrocytes, white blood cells like neutrophils or lymphocytes, platelets. And we know that acute leukemias are going to be typified by their blasts. They are immature blast cells that are released. They are obviously not functioning as mature cells. It's very rapid onset and needs to be treated right away. Chronic leukemias are obviously slow growing, but more importantly, what I want you to know is that it's mature leukocytes that have, because of the malignancy, they are excessive in the blood. They're crowding out all the other healthy cells. Now, the acute ones, I think this is kind of, it's important, but we've gone over it before. And the other thing before we get into the acute versus the chronic leukemias, keep in mind, I will test you on this, that in your bone marrow, it's supply and demand. You only have a certain amount of stem cells. Those stem cells have to receive signals so that some of those stem cells will become red blood cells. Some of them will become platelets. Some of them will be phagocytic neutrophils. Some of them will be lymphocytes. If you have a leukemia, the malignancy is going to alter the distribution so that the person, no matter whether they have ALL or AML or CML, they are going to be anemic. They are going to have bleeding disorders, thrombocytopenia. Depending on which white blood cell, they might have a hard time fighting bacterial infections. They might have problems with the first line of defense in phagocytosis. So those are things that you always keep in mind with leukemias. Then there are 3 specific leukemias that are going to be on the exam. The acute lymphoblastic childhood leukemia, and you end up having the proto-oncogenes as the cause. And again, you're going to overproduce the lymphoblasts at the expense of the red blood cells, leading to anemia, bleeding because of thrombocytopenia, neutropenia, which would mean that phagocytosis would be compromised. And it's a very short course. You have to catch it very quickly, otherwise ALL can be a killer in as little as a few weeks. The adult version of this is acute myeloid leukemia. And the myeloid cell, remember that cell will or can become a red blood cell or white blood cells like neutrophils and megakaryoplasts that lead to platelets. So an acute myeloid leukemia, again, is going to be sudden. It's going to be the myeloid line of cells. And it's going to be blasts. So they're immature blast cells. The thing about the acute myeloid leukemia to keep in mind and to know is that it's caused by a chromosomal translocation. And then when you get to chronic myeloid leukemia, which is adult, old age, it's a form whereby you have unregulated growth of mature myeloid cells, usually neutrophils, but in such an amount that, again, they crowd out all the normal cells. Do I want you to know about the Philadelphia chromosome? Yes. For a 2-point question, it's the most famous chromosomal translocation. And it is characterized by shuffling some of the material from chromosome 9 to 22 and vice versa. And that translocation is what will bring two pieces of DNA that never should be next to one another, and it results in chronic myeloid leukemia. Okay, so that's it for leukemias. The immune system. And this is a review of the immune system that you got in micro, but let's go through it, and I'm going to show you what would be asked and what I will emphasize. I think of the immune system as having 3 lines of defense. The first line, keep them out. That's your physical and chemical barriers that stop the pathogen from getting into the body. If that, however, is breached, your second line of defense is inflammation and sometimes fever. So inflammation, I do want you to know that when a person is evoking an inflammatory response, there is a type of cell that's scattered throughout the body called mast cells that release histamine. Histamine is a very active pharmacological agent that is going to diffuse into the area and cause an increase in capillary permeability, and then also cause vasodilation and increase in smooth muscle contraction. Now, let's take each one of those. When the capillaries become permeable, they pull apart a wee bit in order to deliver phagocytic neutrophils to the wound area. When that happens, however, there'll be some plasma that will also escape. The plasma escaping is going to cause swelling, which is called edema. And the pressure of the swelling is going to trigger pain receptors. So when you think about inflammation, you're going to say the inflamed wound area is going to be hot to the touch, it's going to be painful, it's going to be red, it's going to be swollen. So the capillary permeability is going to be responsible for the edema and the pain. And ta-da, phagocytic neutrophils. That's what you want. This is what you don't want. Now, and I'll talk about phagocytosis in a second. Vasodilation is another thing that histamine can bring about. And when you have the dilation of arterioles to that capillary feeding the wound area, that is going to cause heat, because by dilating, you're going to increase the velocity of the blood flow, and that produces heat. Redness, because most of the blood contains red blood cells, and they're red. So that's the heat and the redness. Again, vasodilation gets as many phagocytic neutrophils to the area as quickly as possible, which is good. And then the last effect of histamine is increase in smooth muscle contraction. This works well for almost every place in the body except respiratory. For every place else in the body, when you contract the smooth muscle, that's going to help contain the pathogen to that wound area and not have it spread. However, when this happens in the respiratory tract, the smooth muscle can actually decrease the ability for a person to move air in and out of the respiratory tract. Okay, phagocytosis. Big thing I just want you to know is that phagocytes are mainly neutrophils, then what happens is they're able to understand where you have a pathogen versus a healthy cell, and they will target that pathogen, engulf, and kill it. And that is a 24/7 protection. It's always ongoing. Since you can get phagocytes because of the process of inflammation to every cell in the body, no matter what tissue, organ system it's in, it's a wonderful way to do it. And there are obviously drawbacks, but inflammation in and of itself is not bad. Having said that, the rest of the course will go into how if it's evoked in a pathological way, it's pathological. All right, so we got the we did the okay, now fever. Fever is only invoked if the body, through the hard school of evolution, realizes that this pathogen is deadlier than the other pathogens. If it's deadly, then like the influenza virus, when people get the flu, they have a fever. The fever, called pyrexia, is a cascade that will give the body extra power to kill the virus. Inflammation, yes. Fever makes it more virucidal. More viruses will die with fever. And influenza, or it could be bacterial like staphylococcus. You don't want these dangerous pathogens, and if they get, you don't want them in, and if they get in, you need an additional help. And the additional help for the second line is always going to be inflammation, but if it's a dangerous pathogen, it's also going to be fever. Fever is a cascade, and the actual pathogen is going to start it. So the pathogen getting in the body is going to be the wake-up call. So that's called an exogenous pyrogen because it came from the outside. Then white blood cells, usually neutrophils, will make their own pyrogen. So it's inside the body, endogenous pyrogen, like interleukin-1 signal molecules that then going to go and be the trigger for the formation of prostaglandin. It's the prostaglandin that's going to go to the hypothalamus in the brain and reset the body temperature. The hypothalamus controls the body temperature. Prostaglandins, which is made because of the immune response to the pathogen, is going to trigger a fever. And it's tightly controlled so that once the fever and inflammation have gotten rid of the pathogen, the fever breaks. Okay, so that is that. So let's get into some, we'll almost get into some pathology. Third line of defense, that's going to be your lymphocytes. That's going to be your specific immune system response. That's going to be your memory response. If you can handle it with the second line of defense, you don't go and knee-jerk to the third line. But if the second line is struggling, the third line will enter. It takes a little bit more time to set up, but it is marvelous at being a final solution, not only at the time, but giving you memory. It means you have lifelong immunity. Okay, so let me go back. Sorry. I move and this thing moves. Okay, so third line, your lymphocytes, they are specific. They have memory. Lymphocytes come in two flavors, B cells and T cells. B lymphocytes or B cells make antibody, and these are the Y-shaped molecules, protein, that can bind to the specific antigens on foreign pathogenic cells, and with other components of the immune system, destroy it. There are also T lymphocytes or T cells. They come in a variety of types. And what's important to know for this exam is the helper T cell and the cytotoxic killer cell. The helper T cell is going to be able, with the release of different cytokines like the interleukins, to be able to orchestrate an attack. would be able to orchestrate the B cells to produce more antibody, these cytotoxic and natural killer cells to go out and kill. And these lymphocytes are mainly, they're found in the blood, but they're mainly stored in the lymph nodes. Okay, so we talked about antigens being foreign. So the antigens are what the antibody attaches to, and the antigen is what the cytotoxic and natural killer cells attach to and then destroy the foreign invader. And then the T helper lymphocyte, which will go into a lot of detail when we get into HIV and AIDS. This just gets into what I said before, is that you need to have the T helper to orchestrate the attack on the pathogen. But you get memory. All right, so what do we need to know for the exam? There are inappropriate immune responses. Usually the immune system is fine. Sometimes it's inappropriate. I want you to know type 1 hypersensitivity reaction and type 3 hypersensitivity reactions. There are 4. We're just going to do 1 and 3 for this exam. It's inappropriate with peanut allergies raging in children to have a peanut be the agent of a child's death. That's inappropriate. It's a peanut. It's not a pathogen. But something triggers this inappropriate response to the peanut as if it is a pathogen. People who have peanut allergies and other types of allergic responses, it could be to peanuts, it could be to ragweed, it could be to oak, it could be because of pollen. All of these are type 1 anaphylactic reactions. On the exam, I would say type 1 anaphylaxis or type 3 immune complex. What you need to know is the underlying pathophysiology. Now, type 1 is always pathological because of the antibody IgE. And what happens is, let's take the peanut allergy. The child eats the peanut for the first time in their life and nothing happens. And that has to do with the fact that the setup for the anaphylactic reaction, which is like take inflammation and push it to the nth degree. And I'll explain how a person can die in a sec. But what is going to happen is that the first time it's called a sensitization step. And in the sensitization step, the immune system is going to make the inappropriate choice. But it's going to take time. So by the time the child's immune system is making the aberrant IgE, the peanut has passed out of the child's system days ago, weeks ago. So the atopic, but the thing is that now everything is activated. They're just waiting for that kid to eat that second peanut butter sandwich. So you've got yourself your B cells, they are memory cells, they are producing an inappropriate IgE. It's inappropriate because IgE will bind to mast cells and release histamine because of a peanut. All right, it does produce memory, so that child is going to be allergic to peanuts for the rest of their life. IgE is the only antibody that binds to mast cells, but they are not symptomatic. It's the second peanut butter sandwich that the child might have a couple of months later. That's going to bring them to the emergency room. Okay, I won't get into how you can get tested because that's not going to be on the exam. The second time the kid has the peanut butter sandwich, they will have an atopic reaction. So the peanut binds to the IgE on the mast cell, and you get massive histamine release. Now, you know that you have a lot of repercussions for histamine. It produces edema and pain and gets everyone involved in a massive inflammation. Sometimes that inflammation is in a particular place. So I'm allergic to pollen. And right about now, I'm going around sucking on antihistamines. But what I get is sneezing and coughing and wheezing. It's a pain, but it's not life-threatening. You just don't want to be beside me. So, on the other hand, if it's going to be the most severe inflammatory reaction of that type 1 anaphylaxis, it's systemic. So the child that eats the second peanut butter sandwich a couple months later, it means that all of the capillaries in their entire body are going to do edema and smooth muscle contraction and vasodilation. And that is going to drive their blood pressure and blood volume down so that they can go very quickly into shock and die. Hello. It seems like every time I move, this thing moves with me. So that's the reason why children who are that allergic to peanuts carry an EpiPen, because epinephrine can act instantaneously when injected and reverses the effect of histamine and saves the child's life. Okay, immune complexes. Immune complexes are important because there are going to be several autoimmune diseases that we'll cover later that are due to type 3 immune complex hypersensitivity disorders. What happens in this particular case is the immune system sees a fragment of something as foreign or different. It's not a cell. It's a fragment of DNA. It's a fragment of a antibody. The one that's going to be on the exam is going to be lupus. And in lupus, which is which can occur mainly in young women, the immune system suddenly sees fragments of DNA as foreign or different in the blood. We all have fragments of DNA as cells are being recycled. None of us have type 3 immune complex syndromes. So that's the mistake that the immune system is making. DNA is not foreign or different. But young women with lupus, the immune system has been triggered. We don't know why, nor can we undo it. So this is going to become a chronic condition. Immune complexes tend to be. So the DNA is seen as foreign or different. You're going to then have the immune system produce a lot of antibodies, IgG antibodies, not IgE, IgG. And they will form these crystalline complexes between the little fragments of DNA and the little antibodies of IgG. Fragments, crystals in blood are going to get caught, especially in capillary beds. And these crystals get caught in the capillary beds. They are going to invoke inflammation, depending on the organ where they get caught, which is usually the kidney, because the kidney have the finest capillaries. You start to create an inflammatory response, and the kidney starts to be destroyed, and you can't rectify that, and you can't renew it, and you can't heal it. So people who have lupus worry because of the memory response that they'll go through acute episodes and then be down a certain percentage of their kidney function. So the DNA is seen as foreign or different. IgG antibodies are going to bind to that DNA to form immune complexes. These complexes get lodged in the kidney's capillary, and they cause inflammation and kidney damage by innocent bystander injury. And many autoimmune diseases are caused by type 3. Okay, immunodeficiencies. Before we get into HIV and AIDS, people can become immunodeficient in other ways. These are merely going to be maybe 3 objective questions. You can have it be inborn, congenital, meaning that the child is born with a mutation in a gene that has to do with the immune system. On the exam, I'm not going to get into ADA deficiency or SCIDs, just for you to know that at times a child can be born with a defective gene that is going to compromise the child's ability to mount a defense against pathogens. The more common is secondary. So, for example, people in their 70s and the 80s, their immune system declines because of age. The cells age, your thymus ages, your lymph nodes age, your lymphocytes age, and that means that they're not going to have as much of a robust reaction and more easily can become immunodeficient. Another way to do this is, and I will ask one 2-point question on this, iatrogenic. Iatrogenic is the medical term for giving a person a drug that has an unintended consequence. And that unintended consequence is some other adverse effect. So, for example, a person has cancer and they're trying to kill the cancer cells with chemotherapy. But many of the chemotherapeutic drugs are amazingly immunosuppressive. So while the person is being treated for the cancer and taking large doses of the chemo, they are at risk of picking up anything that comes their way. So that is an example of an unintended consequence. They're taking the chemo to get rid of the cancer, but they're also now much more vulnerable to picking up infections. So that's an iatrogenic drug. All right, now there are 2 major ways of disrupting the person's immune response. One can be a bone marrow problem. And I do want you to know that a bone marrow problem is going to cause aplastic anemia. And Fanconi's anemia is an example of an inherited type. Aplastic anemia is a terrible anemia. It's not what you think of. It's not iron deficient anemia. What aplastic anemia means is that the red blood cells and white blood cells are just totally shut down. The bone marrow is totally shut down. The stem cells are totally shut down. And if you can't get at the underlying cause, which very often you cannot, you can treat the symptoms, but the person will die of aplastic anemia. You have to have the ability of stem cells to make blood elements and blood cells. When that collapses, you can transfuse the person, but eventually they will die of this type of stem cell problem. Another way to disrupt normal function is to have the lymph node or the cells in the lymph node become neoplastic. And the one that I want you to know for the exam is multiple myeloma. Multiple myeloma is a fatal cancer in which the B cells start producing a abnormal antibody that really has no function, but the B cell that is cancerous is going to grow and divide and crowd out everybody else. And as of now, we have some experimental treatments, but multiple myeloma is a fatal type of cancer due to the fact that B lymphocytes tend to be in high numbers in the lymph and in the lymph nodes. And so if one of those becomes neoplastic and starts to grow and divide uncontrollably, the person then has multiple myeloma. All right, the other thing for a 2-point question is sometimes, as you notice, multiple myeloma is a B cell disorder. Now, aplastic anemia is a total bone marrow collapse. But you could also have some iatrogenic drugs affect B cells more than T cells. So what happens if one of those, like a B lymphocyte or a T lymphocyte, is not made properly or doesn't function? And what we now know is that if the deficiencies are mainly in T lymphocytes, these individuals will have recurrent viral infections. And if the deficiency is in B lymphocytes or B cells, they tend to have recurrent infections with bacteria. Okay, now HIV and AIDS. Because we covered this in lecture, I'm not going to spend a whole lot of time on it. We talked about the life cycle, the binding of the virus to the CD4 receptor, the fusion into the CD4 cell, the unpacking of the RNA, the transcription to DNA by reverse transcriptase, integrase, taking that viral DNA and incorporating into the chromosome, then starting to slowly replicate, and the protease being involved in the maturation and the coming together of the virus. And then the budding out of the cell so that the T helper lymphocyte can continue to survive. I'm not going to ask you about antiretroviral drugs, XX. I do want you to know that the tipping point for a person who has been infected is they're going to seem fine for several years, and then the tipping point is below 200 for the T helper, and then the person acquires an immune deficiency. And for a couple of multiple choice questions, I do want you to know this because these are the hallmarks of people who have AIDS. They don't have all of them, they have some of them. So I do want you to know that Kaposi sarcoma, again, multiple choice means the answer is there. So part of this is recognition. AIDS patients can develop Kaposi sarcoma, non-Hodgkin's lymphoma, wasting syndrome, and AIDS dementia. The opportunistic organisms, fungal, candidiasis and cryptococcus. Candidiasis causes thrush, cryptococcus, meningitis. Another fungal is pneumocystic carinii, which causes fungal pneumonia. That's fungal. Viral. Cytomegalovirus is a type of herpes virus that can infect the cells of the retina and cause blindness. A parasite, Toxoplasmosis gondii, can cause encephalitis. And Mycobacterium tuberculosis is a bacteria that can cause TB. And the fact that the HIV vaccine, we've not been able to do it because of the challenges of the HIV virus, its life cycle, its ability to mutate, its ability to reservoir, and the fact that vaccines don't prevent initial infection or subsequent infection. A vaccine will protect you once a pathogen and you have memory comes into your body and starts a small infection. You can nab it, you can destroy it. You're not going to be able to do that with HIV because of the nature of the T helper orchestrating that incredibly important defense mechanism, and that's the reason for the AIDS. All right, the last topic, cardiac pathophysiology. All right, so what we have for this topic, it's mainly about heart failure. And the heart failure can be acute heart failure, like a heart attack or myocardial infarction. Chronic, which means, especially in the elderly, you can end up having increased demands on the heart as it ages. And so you can't get, you can't meet the body's needs for oxygen. And that is an example of congestive heart failure. You have right-sided heart failure. Now, the only thing that's going to be on the exam is actually, it's not going to be anything on the exam on right-sided heart failure because I told you that I wasn't going to ask you anything on this until we get to pulmonary. So you can just ignore that. I do want you to know that the right side is weaker than the left because it just is a pulmonary circuit to the lung and back, and that the left side is extremely muscular and needs that power to move blood throughout the body. So when you have left-sided heart failure, there are two types, systolic and diastolic heart failure. So systolic heart failure is a loss of contraction of the left ventricle, and so forth and so on. Now, diastolic heart failure, on the other hand, is not about a loss of contractility, but the inability during diastole, during relaxation, of the left ventricle to fill adequately with blood. All right, now, before we get into 3 cardiomyopathies, we're going to first have, and this is going to be a couple of questions, but on pericarditis and cardiac tamponade. Pericarditis is an inflammation of the sac that holds the heart, the pericardium, and like all inflammation, very often this is bacterial in origin, but in all inflammation you got edema. Edema is swelling, edema is fluid accumulation, and what happens is that as you accumulate this fluid in the pericardium, it starts to push on the heart. The water has to go somewhere, there's a little bit more room, and that's the reason why it goes in towards the heart. If it becomes so problematic that the person can't breathe, it's an emergency, and it's called cardiac tamponade. And it means that you have enough fluid that the heart cannot expand during diastole. So there's no filling of the chambers, and that pressure and the consequence of the pressure can, in cardiac tamponade, can lead to the collapse of the right ventricle and the vena cava. Know that. And obviously, if that happens, the person dies quite rapidly of circulatory collapse. All right, now, after that happy news, let's go into the cardiomyopathies. These are diseases of the cardiac myocardial muscle cells. All right, we've got dilated, hypertrophic, and restrictive. Dilated, usually in the elderly population, because the cardiac cells age, they become saggy, they do not contract forcefully enough. So, what is going to be happening? A number of things are going to be happening. One, cardiac output is diminished. It's decreased because if a ventricle cannot contract, it can't force the blood out of the heart into the aorta. Second, blood clots. Because so much blood is left behind and stagnates, that is a trigger for thrombus and emboli formation, or the formation of a blood clot in an unbroken blood vessel or chamber. So that means that people with cardiomyopathies have to worry about strokes and heart attacks. The other is pulmonary edema. Because blood always has to flow, there's going to be a backup. It's called congestion, and the backup is going to be to the pulmonary capillaries. The pressure will be such that the pulmonary capillaries that should only be exchanging gases is also going to start to pump fluid into the alveolar sac. And that's going to cause pulmonary edema, which can be life-threatening. In addition, dilated cardiomyopathy is a long-term disease, and arrhythmias may occur as the pacemaker tries to rectify the situation. And there's also mitral valve incompetence over time because the pressure differentials are so skewed in this disease that can happen. And obviously, between ventricular fibrillation, that can kill you, pulmonary edema can kill you, blood clots can kill you, mitral valve incompetence can also kill you. There you go. And that's the good news for dilated cardiomyopathy. Hypertrophic, young, athletic males are at risk. And because they are young and athletic, and we get to blame testosterone for this, it can manifest. Young man goes to bed at night and doesn't wake up the next morning. That's the reason why it's called sudden death. All right, now what is happening here is that the cardiac muscle cell is responding to testosterone. It shouldn't, and in some cases it does. It's rare, but it does happen. And that means that the cardiac muscle cells start to do hypertrophy. They get larger. Where are they going to go when they expand and get bulky? They're going to go into the empty spaces. So that means that the ventricular space is going to now be transformed into a very small volume as the cardiac cells bulk up into that ventricle. That means that because of the bulking up of the cardiac muscle due to hypertrophy, there is less blood that enters the chamber, meaning there will be less ejected. So the cardiac output is going to go down. In addition, you're going to have backup and congestion, and it's going to go to the pulmonary capillaries, and you're going to start to fill those alveolar sacs with water, causing pulmonary edema. Pacemakers can try to get involved, causing arrhythmias, and cardiac fibrillation can kill you very quickly, and also mitral valve incompetence. So the mitral valve is not functioning properly. And that is going to be an example of a diastolic heart failure, where congestive heart failure right here is an example of systolic heart failure. The last is another diastolic heart failure called restrictive cardiomyopathy, and an example is a person who has amyloidosis. Amyloid proteins are very stiff. They are very invasive. They tend over time to replace the elastic connective tissue in the heart with the stiff amyloid proteins. And that is going to cause a diastolic heart failure because the ventricles are not going to be able to relax enough to fill properly. So again, if you can't fill it because of the stiffness and the lack of ability to do diastole completely, you will have a reduction in stroke volume. You will also have pulmonary edema because of the backup, and arrhythmias and mitral valve incompetence. So those are the cardiomyopathies. Valve dysfunction. Valves can be damaged either by things like cardiomyopathies, but also by bacterial infections, which damage the valves. And on the exam, I will be talking, or just like a 2-point question about the difference whereby you have a stenotic valve, valvular stenosis. The valve is too stiff to close. Or valvular regurgitation, where the valves overlap, but they're so weak that they will regurgitate blood when the ventricles contract back into the atrium. Both of them are going to affect cardiac output, and that will increase cardiac work. The only specific one that'll be on the exam, and that's going to be one question, is a mitral valve prolapse. I want you to know that it's a regurgitation problem, and that it's going to create, that is a very prevalent valve problem, I'll get there, and that it's the most common in the US. All right, chest pain. This is on the last slide, folks. Thank you for hanging in there. Angina or angina, that can be caused by stable chest, or you can have stable chest pain, you can have unstable chest pain, and you can have variant or Prinzmetal chest pain. Stable chest pain is a person who has coronary artery disease. In other words, they're not having a heart attack. They are not having, right, myocardial infarction is the other name for heart attack. What's happening is they're having a slow blockage, a slow buildup of plaque. And an atherosclerotic plaque in the coronary arteries is going to mean that the person can live with that up to a point, but they are going to have diminished ability to do demanding muscular work like climb stairs and go out and garden and mow the 2 acres. So if they overextend their capabilities, they will have angina. It's called stable because it will rectify itself once the person stops exercising or moving. And then once they sit down, then they're all set. Unstable is going to be a person having a myocardial infarction, a person who's having a heart attack. And it's unstable because of that. They have to get medical help immediately. However, both of these are going to be mainly people who are older. Prince metal or variant can happen to people your age. It feels like a heart attack, but it's brought on by something that's causing a spasm in the smooth muscle of the coronary artery. That person does not have coronary artery disease. A common thing that happens in our neck of the woods is you go out when it's minus 10 below. Hello, what in God's name happened here? Minus 10 below, and you can't warm the air, and the very, very cold air causes a spasm in the person's coronary arteries, that smooth muscle. They get out of the cold air, they're going to be fine. But it does mimic the excruciating pain of a heart attack. Okay, but the person with Prince metal or variant, they do not have the next and last thing, coronary artery disease. It tends to be older people because as they age, hormones change, lots of things change, and the coronary artery disease, we'll talk about how you make an atherosclerotic plaque after the first exam. But what's happening here is you're forming a plaque made of cholesterol and other inflammatory agents that it is obstructing the flow of blood to the myocardial cells downstream from where the plaque is at. People can have coronary artery disease for long periods of time and be watched very carefully. And when it's at that tipping point, then you can intervene through surgery and things of that nature. So that's it. So it's a lot. What I would first do is, go over all the terms, know all of them, but then ultimately know the underlying pathophysiology. What is happening? So, for example, stable angina or Prince metal angina. Prince metal angina, the underlying cause is a spasm in the smooth muscle of the coronary artery brought on by intense cold, and so forth and so on. So, have fun. I'm an email away. We'll meet at 5 o'clock on Zoom. First 15 minutes or so, answer any and all questions that people might have. And then I will stay in the Zoom room while you go off and take your respondent's Moodle 50-question exam that you're given 90 minutes, which is time and a half. And I will be in the Moodle room, Zoom room, if you have any questions. Having said that, I will see you soon. Take care. Bye-bye.